Hello everyone, I'm Dr. Anuj Chawla. I'm a foot and ankle specialist working at CK Birla Hospital in Gurgaon. And with me today, we have a special guest, is Prof. Leif Ryd from Stockholm. And he is an orthopedic consultant and he's also a founder of Episerve. So we're going to talk about the company and about the implant, the newest innovation in the cartilage injury management. So we're going to talk about it with the professor. So, welcome, Professor. So, my first question to you is that you made an implant on cartilage injuries in the knee and the ankle. So, I think if you look at the cartilage injuries itself, I mean, it's a very specific term, and a layman person would not understand what exactly is a cartilage injury. So, how do these patients come, or what are the symptoms that they come? That you should actually look for a cartilage problem?
Well, to answer that, you need to differ between the knee joint and the ankle joint. In the ankle joint, what we see is it's oftentimes, the lesion oftentimes stems from after a fracture or a dislocation or a twist of the ankle joint. So you have a rift, you have a cleft, a fissure in the cartilage that doesn't show up on X-ray, and you don't see very much of it. But what happens is that because of the ankle joint moving the way it does, joint fluid is squeezed down into the fissure and creates a great, sometimes very big cyst in the bone. And that bone is under pressure. So the symptoms that the patient feels is an ache. They can have, they're difficult to sleep at night. When they sit, they have an ache in the ankle joint. Depending on if the cartilage lesion itself, there may be a surface lesion too, and that may cause catching problems with the ankle joint and sensations in the joint when on walking or moving the ankle joint. But we see, what we most commonly see are these cysts that come, and our implant is an excellent way of treating those cysts. Now in the knee joint, actually the symptoms are much more diffuse. There's no real specific touch to it. There may again be catching, there may be pain on moving, pain on weight bearing, pain on when you do some special motions in the knee. There are some literature, there is, I think, specifically of a Norwegian study, showing that these patients, they have a lot of pain, a lot of problems in this more diffuse way. And the same kind of problems I actually have from osteoarthritis. But they're certainly different. You seldom see these cysts in the knee. It's a surface cartilage lesion.
And what is the age that we are looking at for cartilage lesions?
Yes, well, I think both, probably in the ankle and in the knee, we are looking at what we call the gap age. Now the gap being patients that are too old to have various kinds of biological treatments, cell transplants, so-called Oates procedure, bone cartilage plugs. There is something called BMAX on the PRP, and they work best in the young patient up to, say, 35 years old. And then on the other side, you have patients that are too young to have a total knee arthroplasty, total knee procedure. So between, let's say, 35 and 65, those are the gap age.
Right. Okay. So just to summarize, so if you, for the ankle, if you suffer from an ankle fracture or you had an ankle injury, and after recovery you still complain of persisting pain in the ankle, you might be having a cartilage lesion of the ankle. The knee, the symptoms are a little bit more diffuse. You can have ache, you can have popping or locking. But any of these things, if you get an MRI, there is a possibility that you might be having a cartilage lesion of the ankle. Is that right?
Yeah, that's good.
Yeah. All right. So you said that, we talked about something called as the gap age, which is the age of 35 to maybe 45 or 50 years, when the healing is not that great for the cartilage. So what is the difference between the conventional techniques, and what are the conventional techniques that we use for these patients, and why or how is Episurf better than the others?
Well, you have what we call the biology, and there are a huge variety. You have cell transplants, you have what they call oats again. You drill out a bone cartilage plug that you insert. You have various types of membranes that you put in the defect together with the ground particles of collagen, for example. So those all rest on biological processes, healing processes. Our implant is a metal implant. It's made specific to fade from MRI images or CT images. We manufacture the implant to fit that particular joint or particular part of the joint with a metal implant. We put it in at a very precise, it needs to sit most of the time just underneath the surrounding cartilage, because if you put a metal implant in and it's sticking up, it will carve away on the opposing cartilage on the other side of the joint, and we can't have that. So we put it in with great precision with the help of instruments that are also patient specific, made to fit that particular joint. And we are the only implant on the market or way of treating this that provides these patient specific implants and instruments, which I think is crucial, important.
Okay, so again, there are lots and lots of options for dealing with the cartilage problem. The traditional way of dealing with it was doing some drilled holes, and then there are other newer techniques which includes transplantation of another cartilage and bone plug from another part of the knee or the ankle, or maybe sometimes growing the cells in the lab and then stitching it back towards its original position. But they all depend upon the biology or the healing potential of the cartilage. That healing potential diminishes with the age. So after the 35, the healing potential significantly diminishes, and those patients have a higher failure rate with all these kind of techniques. So what we have is an implant called as Episurf, which is a customized titanium and hydroxyapatite coated implant. It is customized as per the shape of the patient's bone, based upon the pre-operative CT scan and the MRI imaging, and based upon that, we are giving it. So Prof, one last question. We know that this implant has been there for quite some time in the market. So can you just tell us about its success, or what's the result, and how long is the maximum follow-up that you have?
Well, we started 11 years ago, and our first patient, he was 54 years old at the time, a gym teacher, and he's now 65, and it works perfectly. He has no problem whatever from his knee. He's walking, taking long walks in the Italian Alps every spring. More systematically, we're using the knee osteoarthritis and outcome scale, 5 domains, and we can see a 200% plus improvement in the crucial sports and quality of life domains that are most severely affected by these lesions. So clinically, these patients fare very well. Now, what about revision? That's the other side of clinical results, if you like. And we are very happy to report that our revision rates are extremely low. We've put in about a couple of thousand implants now, 2,000 implants, and we have in the order of 30 revisions. we don't have a single case of loosening or breakage of the implant itself, but we have some cases where the opposing cartilage did not hold up. That cartilage being, as you were, a bit compromised already at the initial surgery. We have a number of cases where the disease progressed in other parts of the knee. So we had to revise it oftentimes to a UKA or a total knee. We have a couple of infections, which always happens in surgery. And so there are various types, but the rates are very low. And most importantly, we don't have any loosening or breakage of the implant itself.
Right. Great. So I think why Episurf or how Episurf is different is because, as Prof mentioned, the revision rate as per their patient data is 1.5%, which is very less. Most of the cartilage procedures, the revision rate can vary between 10 to 20% over 5 years. So I think in that sense, I think definitely it's one of the options to look for. So if you have any cartilage problem or any cartilage lesion, then you can always put a comment on this video and you can contact us and we'll be very happy to help you. And I would really like to thank Prof. Leif for sparing time from his daily and a busy schedule and coming up for this video. Thank you very much.
Thank you very much. Thanks for being here.